Welcome to the South Carolina Medical Association's December 2015 PCMH webinar. This webinar is going to be focused on population health. If you missed last month's webinar, which was an introduction to PCMH, please go back and view that for some introductory comments that provide a basic background introduction to what a patient-centered medical home is. We're going to be diving a little bit more deeply into topics over the next couple of months, and this first topic is going to be focused on population health. When you hear the words population health, what images are conjured in your mind, and what is it that you think it is? We'll be taking just a brief look today at what population health is, and we hope what this will do is it will generate additional conversations for your practice as you think through how can population health have an impact on the care that we're providing for our patients. What are the concepts of population health that can maybe help us to rethink some of the care and the methods of care and the way that we're thinking about providing care to our patients. My name is Scott Holtstrand, and I'm the PCMH Project Director at the South Carolina Medical Association. And so let's go ahead and get on with this topic. So what is population health? Here is one of the original definitions of population health, which was published in 2003. And it's a little bit hard to understand, honestly, if you just read it in a vacuum. But let's go ahead and read it, and then we'll talk about what this means. So population health is the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And so clearly, population health is focused not on a specific individual. A lot of physician care has been focused on one individual at a time, and that is still necessary. When an individual comes to you with a chronic or acute need, you need to be focused on that individual and providing the best care possible at that moment. But what population health recognizes is that we need to be caring not only for each patient as they come in, we need to start thinking about caring for the populations of our patients, for groups of patients. And some of that care will involve reaching out to patients when they're not with us, thinking more deeply about our patients when they're not in our office and how we can provide the best level of care that we can. If you look also at this definition, it defines population health as health outcomes. So the focus of population health is not as much on it certainly involves the provision of care, but really it's the ends and not the means. The means are very important still, but the end being positive and improved health outcomes for groups of individuals that we're caring for. It also, as you can see, includes the distribution of such outcomes within the group, and so we're going to look within the group. We're going to analyze different reasons why some people may respond better to certain treatment regimens or certain approaches, and we're going to be thinking about disparities of care and population health and figuring out why is this zip code, for example, not performing as well on their health versus another zip code that is. And so we start in population health thinking more broadly about caring for our patients, but that broad level of care will eventually drill down into the specific ways in which we're going to be providing patient care. One thing that population health does is it helps reorient ourselves as providers of care. There's, I will admit, a lot of controversy about these concepts right now, but this comes from the County Health Rankings organization that is, I guess, more well known for providing specific county health ranking data for each county in the nation. But what this chart does is it hypothesizes what is it that goes into the health outcomes of a patient. And if you look at this, they've assigned various percentages of things that they believe go into health factors that lead to health outcomes. And if you look, this is where it gets a little controversial for physician practices. Only 20% of health outcomes are attributed to clinical care. And another 80% is allocated to other things like health behaviors, social and economic factors, and the physical environment that a patient may be in. If you think about it, though, that this is not too surprising. The choices that a patient makes are vital to their health. And I hear complaints all the time about patient compliance and how physicians are helpless unless a patient is compliant with the treatment and prescription regimens that physicians give to their patients. And what this chart does is it reflects that thought, that if a patient chooses, for example, to smoke and not exercise and engage in risky sexual activity and abuse alcohol and drugs and doesn't concern themselves with education or employment, doesn't have a family network of support, lives in a dangerous neighborhood that is full of environmental hazards and other things like that, doesn't have transportation to care, all these things add up to a patient that's going to have a hard time getting well, even if the clinical care is the best and highest quality. And so what population health does is it reorients the physician and the provider away from thinking that their care is the end all, and helps the physician and provider community to start thinking through, where can we influence outside of clinical care the health behavior and other issues related to patients. And I will say that I firmly believe that the physician community is well positioned to answer these questions, well positioned to lead the effort to engage patients outside of the four walls of their practice. And I also believe that healthcare is moving outside of the four walls very quickly. And so the physician community needs to be on the cutting edge of providing population health care that thinks about care in a way that would be reflective of this chart. Of course, we could argue about these percentages, but I think anybody would agree, at least, that is not just clinical care. Clinical care is not the end-all and be-all of a patient's health. There are other factors that are involved. So population's health goal, of course, is a healthy patient, good outcomes, not just for individual patients, like we said, but for patient populations. And it's to prevent going to the emergency department, prevent surgery, or prevent long hospital stays, prevent having to do excessive imaging or other studies. And so the goal is good outcomes, and those good outcomes are measurable in what we are, in some respects, preventing. It's also measurable in the quality of care we're providing proactively. But what we're trying to do is get our patients well and keep them out of situations that are expensive and not helpful or healthful for our patient populations. So who are our patient populations? Well, this is just an example. You may have heard of the My Health First network, which is a large network of providers in the Greenville and surrounding areas. There are other networks out there. This is just for the sake of example. But in some cases, if you are in that area, your population in that network are all the patients that are part of that network. And there's different subpopulations. And so the population is all the patients that are part of your physician practice. An example of one is pictured here. But then in even a broader context, because you are coordinating care across a big network in some cases, then your population is the entire network. And so here we have a chart that reflects different patients who have different risks. And so when we're doing population health, what we want to do is we want to provide the level of care that is needed dependent upon the risk assessment we've done for our patient population. So if you look at the top of this chart, our highest risk patients, even though they are our fewest patients, and a lot of times folks will attribute 5% to this top green triangle, but 5% of your patients are attributing or resulting in 50% of healthcare costs. And so what we want to do in population health is think about the patients that are in this high-risk category and how can we care for them, and how can we design processes and structures so that so that these patients have a better chance of managing their care. While at the same time, if you look at this blue category, the risk-rising patients, these are patients that are not high risk yet but are moving in that direction. What can we do, thinking about broad categories of patients, to better care for them and better manage the needs of patients so they don't enter into the high-risk category? And then, of course, preventative care for the low-risk patients. We want to think through, how can we prevent these patients from even getting into the rising risk categories. At any given moment in a patient population, a lot of estimates suggest that 20% of the risk-rising patients are at risk for going into the high-risk category. And so, again, it's very important to be not just thinking about your high-risk patients and how you manage their care, but also the rising risk patients. There's also, we've discussed this to some extent, but there's another reorientation that happens with population health. In the traditional patient model, we've waited for our patient to come visit us in our office. If they have an acute care need or if they have a chronic condition and they remember, they come to our office and we provide care to them in the office. And that's how we've done it, one patient at a time coming into our office. What population health does, though, is it reorients us to think, again, like I've said, outside of the four walls of our office. And how are we going to provide care to them? How are we going to reach out and provide the care that they need when they're not with us? Some of that involves using registries and leveraging the power of our electronic medical record systems to monitor our patients when they're not with us and to make sure that they're coming in for the needs for the care that they need. It may involve some kinds of home care or home monitoring. There's lots of ways that we can reach outside of the four walls of our physician practice. It may also involve getting involved in schools. I know of one physician practice that's even thinking about starting a school so that they can better provide care for their patients and better integrate care through into their lives. And so there's a lot of ways that we can reorient ourselves, but we do need to be thinking about how can we get outside of our practice, maybe not even physically, but at least electronically or in the way that we monitor our patients. And here's why we need to be thinking about that. We have a busy practice. Here's a picture of probably a waiting room that might look like yours. Patients are filling our days, and so we can start thinking that we're seeing all of our patients. We think we're so busy, our volumes are so high that it just seems like we're seeing everybody. But that may not be the case, and you don't know that case. You don't know that that's the case unless you start monitoring your patients and seeing, have all of our diabetics come for follow-ups? Have our asthma patients come in for follow-ups? Are our patients coming in for their yearly well visits? Are they receiving the colorectal and breast cancer screenings that they should be? Are they receiving the immunizations that are suggested? Again, because you're so busy, you can start thinking, oh, I'm giving all the shots I'm supposed to be giving, or all my patients are getting screened that should be. But until you start measuring yourself, you don't know if you're actually following the best practices that are suggested through evidence-based guidelines. And what happens is we have patients that start slipping through the cracks, and when we start missing out on opportunities to provide care to them. Leveraging EMR is something that is very important. This is something you can't track on your own. If you don't have EMR, this is very difficult. It's still possible, but very difficult to do population health without an EMR. Epic is just an example. Y'all probably have a variety of EMRs out there, but whatever EMR you have, you can leverage it to make sure that patients are making it to appointments. You can leverage it to identify patients who have missed needed services and using it even to reach out to them via email. Or I know some EMRs that can text and call patients directly from the EMR. And so this is something that EMRs are often much more powerful than we give them credit for. And I encourage you to learn your EMR and figure out how can we best use it to enhance our population health services. Again, this is just an example of the My Health First network. There's lots of other networks out there in the state. And one big aspect of population health management are patient-centered medical homes. Patient-centered medical homes must do population health management in order to be recognized. And so it's very important that if you're part of a network, or even if you're just independent, and that's fine as well, and not operating within a network, you want to make sure that you are even if you're not recognized as a patient-centered medical home, that you're doing the things that a patient-centered medical home does. If you're not recognized and want to be recognized, the Medical Association has a program that can assist you with it for free, and be happy to talk with you about that if you have any questions. My email will be at the end of this presentation if you want to view it. But population health management involves not just you independently, but in the end, whether you're part of the network or not, you will be working with other patient-centered medical homes, other specialty practices to provide the care that is required. So it does involve reaching out to patients, monitoring them on the EMR, giving patients access to you on their smartphones so that they can know when they need to come in. Using patient portal is very important. Home monitoring type services, emailing your patients, using your EMR to remind yourself of what patients need when they come in, but also to remind your clinical coordinators or nurses or staff of patients who have missed needed preventative care services or chronic care visits that they haven't been returning for. So the expected results of population health is really the triple aim of healthcare. If you do population health well, you're going to lower the cost of care because you're not letting patients slip through the cracks. Patients that need services are getting them when they need them and not getting them late or never at all, which will reduce hospitalizations, reduce ED visits, because you are better caring for your patients. The patient experience will be better as well because patients, they are always impressed when you reach out to them. Well, I say always. They're often impressed when you reach out to them because they're sometimes surprised that you're actually monitoring what kind of care they should be getting. And many patients are appreciative of you making sure that they're getting the care that they need for the betterment of their health. And then, of course, better health outcomes, which is what this is all about. It's about getting our patients well. And the thing is that when we don't focus outside of our practice, when we don't concern ourselves with populations, and when we don't involve ourselves in patient care beyond just clinical care, a lot of times patients don't get better. And so in this era of healthcare, we are recognizing that it's becoming more and more important to think about caring for populations and then providing a level of care that is suggestive or that has been suggested by research and other data as improving the health outcomes for your patients. And so that's all for now on population health. We could certainly dive deeper into this topic, and we likely will in the future. But we certainly welcome your questions, and we look forward to next month's topic. Thanks.